Welcome to the Derm Vet podcast, where pet skin is always in. I'm Dr. Ashley Bourgeois, board-certified veterinary dermatologist, skin nerd, and your go-to guide for everything itchy, smelly, and inflamed. I'm here to take the itch out of your day and make derm more fun than frustrating. Grab your microscope and let's focus in. Well, welcome everyone to another episode of the Derm Vet podcast. This is going to be a super interesting talk about something that probably a lot of you are not aware of, and that is venomous insect testing. I think it's something that, not as many people know exists. Not every dermatologist does it, so I just want to preface it there, but it is something within our clinics that we are doing more and more of. So I asked my friend Trenton Ewing, who is a boarded veterinary dermatologist with Animal Dermatology Clinic in Pasadena, California, to join us today. Why? Because just about every time I have one come in and I have a question, I email Trent and say, what do you do with this? Because it is something that's nuanced. It's not as common, right? Like we all allergy test for environmental allergens, but venomous insect testing is really not something that's done as often. So, Trent, I just want to say, first of all, go Cyclones. We are both wearing our Iowa State gear. I told him I wore it for him because I went to undergrad at Iowa State. And Trent, what's your connection to Ames?
Undergrad and vet school. I was there for 8 years.
Double. That's okay. That's double the time I was in good old Ames, Iowa. And listen, I love it. I love a college town, so I really adored my time there. But besides Go Cyclones, Dr. Ewing, thank you so much for giving up your time to be on the Derm Vet podcast today.
Oh, yeah, happy to be here.
So let's start simple. And actually, I'm kind of curious about this question. As you've become one of our company's guru and also Dr. Mona Board, who's in San Diego, kind of one of the leaders in this industry, you and her have become the two people that really a lot of people in our company have relied on to ask questions and information. So can you just start by telling me what kind of spiked your interest in this? Like what made you think like, cool, I'm going to be one of the venomous insect people?
Yeah, so, I mean, having been a resident, you've got to pick a research project, and, my initial idea was something to do with skin testing, and it kinda got shot down. So when I was puzzling over it one day, I was talking to a client through this venomous insect process. It was something that was a little bit new to me, but we had done it in Pasadena for a while, and they actually asked me, "Well, how likely is this to be effective, and what are the risks?" And I was able to give them somewhat of an answer, but when I'd asked my mentors, they didn't really have a concrete answer for me. They said, you should ask Mona Board down in San Diego. She does most of this. And so I reached out to Mona next time I was shadowing down there, and she said, well, we really don't know. Maybe you ought to do a research project on it. So it really was kind of spurred on by just a simple client question. And then from there, Mona was really instrumental in helping guide me through that process and providing the bulk of the cases for that initial research project. Most of those came from San Diego, but yeah, it just kind of spread from there. And once you're the person who put out the paper, they're the person who gets called. So it just kind of grew from there.
So, snapshot, what did your paper end up showing for those that are listening?
So it was a big review of safety and efficacy, and it showed like the cliff notes really, really safe. Something like less than 3% of dogs overall having or less than 3% of treatments having some kind of adverse event, typically limited to like injection site itch when we talk about the actual therapy. And efficacy was quite high. I mean, dogs on maintenance injections were totally protected from future bee sting reactions. And as a whole population, even dogs just starting that therapy, which at that time we did in a somewhat slower and different manner, but even they, like, 85% of those dogs did quite well when they were stung again. So it showed high efficacy, high safety. And that also is encouraging because we were talking about, well, what do I want to develop as my niche? Picking the thing that's safe and works well and saves lives. It's a good pick.
Yeah, I feel like that's pretty good. Good job. It's a nice thing to actually have your resident project like spark an interest, whereas like my resident project like made me run for the hills. I didn't mind just like low level light therapy, which can totally be reasonable, right? The hard thing with that is every setting being different every time, like every protocol can be so different. So though mine wasn't showing as much efficacy in like atopic dermatitis, you can make one change and maybe have a different study. But, I'm glad you got to lean into yours, whereas some of us learned to dread ours a little bit. So, again, this is something that I think a lot of people don't know exists. And I've been reaching out to a lot more recently because it's become a bit more known where we practice in Portland, Oregon, that we do this. So I'm getting more and more of these coming in and more experience. But for those who are not familiar, can you just walk us through the history of a typical dog? Have you ever done not a dog? It's all dogs, right?
I have not, but our San Diego office has done a cat, and there are some case reports on like I think there's a gibbon and a couple horses and things like that. So
Wow.
hypothetically, yeah, you could you could do other animals. I haven't had the chance yet.
Okay, that's cool. Given. What's a typical history, knowing that most of these are dogs, that a dog presents to you as an initial exam for this venomous insect testing?
Yeah, and actually, just out of there's a group in Europe that does a lot of research, and they did a really excellent review paper of kind of like the clinical history of most of these animals. But they tend to be quite young dogs, often 2 years or younger. I think in my study, a quarter of those patients were under a year of age, or just about a year of age. Tend to be a little bit smaller, and oh, cats are fighting. Sorry,
Oh, well, as we do
I
on a veterinary
know. Get
podcast,
out of
okay, it
here.
is welcome. It is okay. Are cats
I'd
okay?
rather
That's
didn't
the
fight.
bigger question.
Yeah, my wife's cat's being a brat. So
Okay.
yeah, they tend to
What is
be
your
they tend to be younger animals. Purebreds seem to be predisposed, often stings on the face or near the oral cavity, and yeah, can be any breed, any age, but those smaller dogs tend to be disproportionately affected under 10 kilograms, 22 pounds or so. And typically, by the time they come to see me, it's not the first sting, unless they had a major episode of collapse on that first episode. Usually, it's because their symptoms have progressed and it might be the second or third sting by the time they come through the door. And we do know in the neighborhood of 40 to 50% of animals, almost no matter what their initial reaction was, will have a progression the next sting. And if their initial reaction was severe, two-thirds of those dogs will still have a severe reaction again. So, pretty similar to human statistics.
And I'd say, like, similar to you, especially the cohort in the last year that I've started seeing more and more, I feel like it's usually they've had 2 or 3 stings. Like you said, like, they have the one where maybe so this dog recently I had this like puppy, as you mentioned, mostly of them have been younger, like, ate the bee or like was sniffing around and got the bee in the oral cavity and like had some scratching at the face and like swelling at the face, but was okay. But then the next one was like collapse, run to the ER vet. And it's not like you can put these dogs in a bubble and say never see a venomous insect again. Even if you say like don't bring them hiking and stuff, this dog literally is in the backyard. So what am I gonna tell 4-month-old golden retriever puppy's owner? Like, just never let them in the backyard? Like, it's already happened 2 times. But it is the scary part is, like, the collapse, the progression, and just thinking about how this can truly be, like, something life-threatening that can happen for the rest of that pet's life is really scary.
Yeah, especially like owners, I find express anxiety because there's such a lack of control, right? Like you can't realistically prevent it. You can't realistically do anything about it yourself. So, I mean, I think that's the other value of the therapy is it allows you to do something proactive that is likely to prevent that, really terrible event from occurring again. And I think, especially after that first sting, when a patient gets challenged and they do well, the level of anxiety owners express goes way down, which I think is also valuable.
Yeah, and to your point, the one I just had yesterday that I was asking you about, that was like the owner's huge fear was she lives an hour from us, so she's not even in an area where there is an ER clinic. Like, she had to like get the dog in the car and like just hope and rush an hour here and then just hope for the best, which is really scary. And so she mentioned, she's like, I'm just always nervous that this dog who's very social, loves to be outdoors, like, she has some things at home to help, but you can't always be staring at your dog to see what they get into. So I think that's really important to recognize like there is anxiety around this that exists for these owners. And this is the only thing that can really attempt to be proactive besides say you're locked in the house for the rest of your life. So now let's go like to the testing. So we have the dog that has a history, very typical. Let's just say like 9-month old dachshund. I'll give you one of mine. 9-month old dachshund has had 2 episodes. It's collapsed. I'll give a props to Pretzel. We've been managing her for a year and a half and she's been doing great, but that's how she presented to me, Pretzel the dachshund. So we have this collapse. They've come to you and they say, okay, I've had these episodes. I'm not exactly sure what it is, or maybe I am pretty sure it's a bee. Kind of walk me through the testing process. What are the things that you test for? And how you kind of talk the owners through that.
Sure. So there's a couple steps to go through. First is, was it a confirmed sting? Did they actually see, or did they just find their, dog covered in hives or collapsed in the yard, or whatever it might be? Because that can help guide you one way or another. But if we're relatively certain it was a venomous insect of some kind, the first thing we do is make sure we've had our drug withdrawal, so we even qualify for testing, which is very similar to skin testing. 2 weeks off of antihistamines. A month off of steroids, maybe 2 months off of an injectable steroid, depending on the duration of activity of whatever steroid was given. So pretty standard withdrawals there. And then ideally, especially if it was the first sting, you want to wait until at least 3 weeks after that to make sure you're not in sort of this refractory period where they're not primed to react again on testing. But if we
That's
meet
why
all
I
of those
think that one
criteria,
that's why
sorry?
they have one sting that you wait.
Yeah, because typically if they've reacted to that second sting, you know they're going to react reliably to it. But if that first sting and episode of collapse was the first known exposure, then ideally after that 3 week period, so you're not going to miss it as you do your testing. Um, you do have to make sure, because with skin testing, they need to be sedated. They're good candidates for sedation. And if they're not, then, there's other ways around that. We can make some compromises, but really the skin test kind of remains the gold standard in veterinary medicine. And then you have regionally specific allergen profiles. So in the US, it's pretty similar across the board: honeybee, wasp, yellow jacket, yellow hornet, white faced hornet. And you start at low concentrations and you do your same intradermal injections just like you would for a standard allergy test. And every 10 minutes or so, you increase tenfold. And then once you start seeing reactions, you stop increasing. And there's a cutoff for these. So at a certain point, because you're just injecting concentrated venom, they might start having like skin irritant reactions to that. But most of the time with positives, they react quite low on the dilution level. So the total amount of volume that you inject of these allergens is quite low. It's not nearly as much as they get in a single insect sting, for example. Once you have those positives, you're good to then go on and do your desensitization. If they're not a good candidate for sedation, you could consider serology, but that tends to be, this is blood testing, that tends to be pretty unreliable in veterinary medicine. The best potential is with the actually molecular allergology approach, which I'm sure you've had an episode on this stage of the PAX testing that NextMune does. Their internal data suggests it's quite good, but they haven't really had an external study to validate that. But in human medicine, that molecular approach to blood testing actually is considered quite reliable, and they'll use that either in place of or concurrently with skin testing. Humans tend to be a little more resistant to the idea of the longer skin test, so you'll see more blood testing in human medicine. But that's sort of how you make that determination.
And when you're doing the testing and you're injecting them with these venomous insects, similar to skin testing, you have your histamine and your saline to kind of give you, again, like what does a positive look like for that particular pet, and then your saline to kind of show what a negative is. Because I know when I have done these tests, sometimes it gets a little tricky when you're kind of just starting to climb up that dilution, right? And every dog reacts differently, kind of like skin testing. Some are like bright red and it's exciting. Some are more like, I'm swollen. So just for those listening, we do kind of have a positive and negative control. I personally don't have them inject the histamine and saline every time I go up, just because I have a pretty good idea of what that dog looks like by the first one. It seems like you're pretty similar.
Yeah, I'd say I might repeat it at like 30 or 40 minutes if it seems like it's reducing in size, but honestly, it's pretty consistent. And to your point, too, sometimes with that irritant reaction, as you test those venoms, it's actually, you have to wait a little bit and see if that reaction fades. So it can be a little trickier than a standard skin test. Absolutely.
And what do you find is the most common culprit?
Typically honeybees, and part of that is they inject a lot of venom compared to any of the vespid insects. So something like up to 10 times as much. You might talk about 100 micrograms per sting versus 10 to 15 for your wasp, yellow jacket, etc. Yellow jackets do pop up quite a bit too, and there's some cross reactivity, I believe, with their hyaluronidase enzyme. We might not that might not be totally accurate, but they have some
Gotta
cross
put your
reactivity
smart.
with honeybee venom. So you'll see some co-sensitization between those two in particular. It would be quite uncommon to be polysensitized to the degree where you're sensitive to all five. Honestly, more than two is quite rare, and typically it's just single sensitization to honeybee.
And what do you find if you have to do so I know we're gonna talk about the protocol, but say you do get like wasp and honeybee or you get 2 positives for that potential pet, which is what I always tell owners, it's really important for us to test them, right? Because sometimes you're like, "Well, but I know it was this, why do we even have to test?" And 1, a lot of times you can know what it is, right? But it's actually really hard sometimes to actually find the venomous insect themselves, or they just assume that's what it was. But then I always tell them too, like, what if there's something else that your pet's allergic to and we can hopefully pick up on it. But if you have two, can you desensitize them to two venomous insects?
Yeah, absolutely. It's as simple as just dividing the total volume. So if you're injecting like half a milliliter at a maintenance frequency or something similar, you just do two and a half of each. Or if you're in a situation where you were desensitizing to three, you might preferentially put, half of it honeybee and, a quarter of it the two vaspid insects. Again, because honeybees tend to have more allergenic venom, they tend to have more like a higher volume injected. So we tend to prioritize those, if there's kind of an uneven split for things.
And so let's take a very standard case, right? So as you mentioned, like most of mine are honeybee. I have one that's two venoms. So let's take the dog. You do the testing. They're positive for honeybee, which would be the most common thing we see. Then what does desensitization look like? I think this is important for people listening to realize because it's quite different than what we commonly do for allergen specific immunotherapy for pollens as far as desensitizing them. We do have protocols where we desensitize pollen allergic dogs in the clinic. But we often can actually have owners do this at home, but this is quite different. So, what does that desensitization protocol look like for you?
Yeah, and I think that's the biggest point is it is done in the clinic, which is a barrier for some folks that we have to be cognizant of, and there's ways we can work around that too. So there's a traditional approach where they show up that morning, ideally having been pre-medicated with an antihistamine of some kind, like cetirizine, for example, or Zyrtec, and they get an IV catheter placed, they get their vitals taken, they get that injection of slowly increasing concentrations of venom under the skin. And there's specific, charts and volumes and schedules depending on your approach. But the idea is you start a small volume, increase the volume, then bump up the concentration. And traditionally, that'd be over the course of about 15 weeks. So that's 15 weekly visits to the clinic where they're catheterized every time and, they're monitored for about 2 hours post injection and then they go home. If we're talking about rapid protocols, which are kind of emerging in veterinary medicine, that can be anywhere from a 2 week rapid induction protocol to a 5 week. And I think most of our clinics do a 5 week rapid induction. And it's the same process, but they get, for example, 3 injections per visit. And then it's only 5 visits to the clinic. They're monitored for a total of 6 hours, so 2 hours per injection. And then, they go home. And at the conclusion of that, once they've had that induction or build out phase completed, the maintenance injections are just monthly, again, given in the clinic so they can be monitored, but they're not catheterized every time. They don't need an IV catheter. And generally, at that stage, they're very tolerant of the therapy. If they've had an issue, it's most likely to be during induction and during early induction specifically. And one other advantage besides limiting the number of trips to the clinic with the rapid protocols is hypothetically they should be protected sooner. And in human medicine, the faster you do the induction, the less likely they are to have a side effect from that process. So there's a lot of potential benefits to kind of trying to accelerate this. But some people get a little hesitant when we say rapid or rush. They're like, oh, that sounds unsafe and not very careful. But really, the data, at least in human medicine, shows that should be the safest approach overall.
Especially if you're talking about like, at the time of us recording this, it's summer here. And so we're seeing a surge of them coming in. It's really difficult, again, just to say, okay, well, because I often get asked, like, how fast will it work? How fast will it work? Right. And that's really tough for owners to kind of accept, like, okay, well, if we don't know it's going to work, we're going to do this for 15 weeks, which, like you said, it's a big barrier for a lot of people, especially they're not like your next door neighbors that can come in that easily. So similar to like we just do the rapid protocol because for me, just ease for the owner, still very, very safe. We're still monitoring them the entire time. When I years ago was a resident in California, we used to do the standard and it really would it take not that there's anything wrong with necessarily doing that, but it would take a long time, and dogs got really tired of coming in for an IV catheter, by, like, the 7th or 8th visit, especially because, like you said, a lot of these dogs are young. So most of mine are, like, under a year of age, so we are having to really be thoughtful of just they might not wanna be locked up all day, while we're doing these protocols. So a lot of times they hang out in the office with me if we can, right?
Yeah.
Like, depending on what day it is, because it is stressful for, like, a 4-month-old puppy to spend 8 hours, weekly sitting in a kennel just, like, getting because we TPR them every 30 minutes. So that's a
Yeah, a
lot.
lot of contact.
Yeah, you have to think about that and just, what they'll kind of tolerate as well. To your point, it can be a lot for them. And then you even told me before we hopped on, as we were talking about this, you even told me that there's protocols that go faster that you have read about and considered. Sneak
Yeah.
peek, because neither one of us have done this, but tell people just where this could even go.
So, the fastest published protocol with multiple dogs, and this was a 10-dog study, again, out of that group from Switzerland, they do it 2 weeks. So first first week, they get, up to the second lowest concentration. It's like 5 or 6 injections, I think. And then that second week, they just get 2 injections of the full concentration. Each one is a half a milliliter. So basically somewhere between half to a full bee sting, like 30 minutes apart. They get 2 of them, and then they're good to go. They're on maintenance. And there's a single case report of what's the most common human protocol, which is called Ultra Rush, where it's 6 hours. They go through the whole induction. And it ends up being like 3 bee stings over the course of 6 hours if we're talking about total micrograms of venom that they get. So some pretty intense protocols, but importantly, all those dogs did well. I think the Ultra Rush dog had some itch at one point, which resolved with steroid administration. And then similarly, the 2 week Rush dogs, of the 10, I think 3 had some injection site itch at the end of the first day. And then the second day, a week later, they were fine.
That's crazy. I mean, it is it doesn't make sense in your head, right? Like, I could understand why that would be, like, really scary for owners, and until you get used to doing it and, you see those things and just see that they sit there, like, looking at you totally fine for the most part, it's pretty wild. So, you get through that, and so what I always get asked by owners, which I'm sure you do too, we get through our 5 weeks, we go to maintenance monthly. How long? How long do we do those monthly injections? Because this can be very variable depending on the clinician, what they do. But I know you've looked
Yeah.
in some literature about this and kind of told us that the longer the better, but walk us through that.
Yeah. And most of those practices are still based on human medicine because um, as a human guideline, you talk about 5 years is generally considered the minimum. And if you had a very severe initial reaction, indefinitely, but they do taper down the frequency. So that might be quarterly long term, like every 3 months instead of every month. In that European group, again, in Switzerland, they tend to taper down. So by the time they're through the first year, they're at every 6 weeks. And then years 3 through 5, it's every 8 weeks or something like that. But there's not been a good study where, 5 years down the road, they stop the immunotherapy and then wait for the dog to get stung again because honestly, we haven't had very many patients on the therapy for that duration that aren't lost to follow up for one reason or another. So it's really hard compared to human medicine where people are usually relatively easy to track down. Um, but yeah, typically we say at least give us the year at monthly. And from there, we can discuss like if it's a practicality thing, okay, we can try every 6 weeks, we can try every 8 weeks down the road. But there's likely not going to be a point where we say you can definitely stop this therapy and assume you'll continue to be protected. But, there's reason to believe that we should be able to decrease the frequency at the very least.
I always tell owners just like at this point, it's really hard to get data about this, right? Because one, like you said, we people move, we lose to follow up. If they did well, maybe they're not as worried about in the future. Cause it's not like allergists are just like, I'm itchy. It's like you don't know if they've been exposed, you don't know if they were and were fine. I always tell owners too that it's a tough thing to kind of do because no one's gonna like stick their dog in a room with a bee and just see what happens, right? There's also like an avoidance portion to it because of the
Yeah.
consequences. It's not like pollens
Mona
where
did
they're
have a client do that though.
you
After the
what?
first year, After the first year when Mona started doing this, one of her clients actually did take their dog to the park to get stung intentionally to see if it
On
worked.
purpose. Oh, that's
Yeah, it did.
hilarious. Yeah. Oh, yeah, that's funny. Well, it does, never say never. Never say never. Okay, so I always kind of tell them like, hey, ideally we continue this lifelong. We can kind of see how the first couple of years go. And then, like you said, we could always look into frequency. Most people, if they live nearby, by the time we get to those monthly or they're just 2 hours quick in and quick out, so they don't really mind them too much if it does make a difference. And then so finally, let's talk through like two last things. One, do you have them go home with anything else just in preparation, right? And then two, what is our expectation? It's not necessarily they'll have zero reaction ever again, right? What could good look like as far as a response?
Yeah. So, and that's a good point too. When we talk about response to therapy, it is generally defined as a reduction in severity of reaction. So again, most of the dogs come to us having had collapse, and that's true across like all the research articles where they're trying to define success. So if it was collapse before, success would be hives or less kind of thing. And so that's kind of what we're looking at when we talk about those really high response rates. Um, and so some dogs, there's literally no reaction, or they get like a little swelling at the site of the sting or something like that, or just some discomfort. But some dogs might still have a little like urticarial, a little hive breakout, something like that. But we're trying to avoid that, profound blood pressure loss, collapse, all of those things. And we're generally, again, quite successful in that, depending on the study read, 85 to nearly 100%. Um, when we talk about ways what they can do at home, there's two kind of categories of consideration. One you already mentioned is prevention. So physical protection can be helpful for some dogs, depending on their most common route of exposure, whether it's wearing boots or if they tend to ingest the bees, you can get what's called an outfox field guard, which is just a mesh hood, so that mechanical barrier can be helpful. But we do make sort of sting emergency kits, I guess you could call them, which is generally epinephrine, diphenhydramine, which is Benadryl, and dexamethasone as pre-measured injections or vials sent home with syringes marked for them. I tend to send home preloaded syringes, so that way, you don't have to like try and carefully draw something up when your dog's collapsed in front of you. That's obviously very stressful. Um, and those do require a little bit of training on the owner's part. So they need to know how to give an intramuscular injection for the epinephrine, which is really important for appropriate absorption. Um, and generally, they're able to do that because if they need to, their dog has collapsed. So by definition, there's not going to be a whole lot of resistance there. And that makes some folks nervous, but some folks really appreciate having something on hand that they can just bring with them. Typically, those kits we replace every 3 months or so, or 2 months, depending on what form you send it home in. And honestly, a lot of folks don't end up needing them because you tell them give this if there's collapse. Don't give it if it's just like we get some hives or some itch or irritation. But that is sort of the backup plan.
Awesome. Yeah, it's just nice to have those options. Again, like I have an owner who next week, like they're going camping and they're just like, well, what do we do? And it was kind of the same conversation. Like, don't just like give it to give it, but just have something on hand that if you are in that situation that, we can try to give some support until you can get somewhere. But yeah, it's just really nice to have the option. Again, not everybody does this venomous insect testing, but we're seeing it done more and more. And it's been a nice experience just to be able to offer people something that's really scary, that they can get preventatives for. It's something we see a lot of referrals from ER clinics in the local area, once they kind of see that exposure. And with that, Trent, I just want to say again, thank you for being on the Derm Vet podcast and teaching everyone about your expertise. We will look forward to seeing you next week, where we're going to dive into something I know nothing about, and that is hyperbaric oxygen therapy. But I really appreciate your
I don't,
time today talking to us about venomous insects.
yeah, happy to be here. I don't know if that poem was intentional, but it was a good one.
Sometimes you swing and you get one.
All right. Thanks for having me.